I'm delighted to be here. Sorry I missed the morning. Came just before lunch, thankfully, because the brownie was massive and delicious, which is great. So, as Louise said, I am called Louise Bramley. I work at Nottingham University Hospital's NHS Trust in the Institute for Nursing and Midwifery Care Excellence, which is really all about staff experience, nurses and midwives within our trust, and helping to make the connections between happy staff, happy patients. So these are some of my fellow colleagues who also worked on this programme. Joe Cooper and Joseph Manning were the two that conceptualised the idea. I just operationalise it, which is why I'm here talking about it, and Jodie is one of our fellows, and we were all there when we received our award, which was great. So in context, really, we have an internationally recognised shortage of registered nurses and midwives. We work in a huge trust, so NUH, Nottingham University Hospitals, we have over 15,000 staff, and 1/3 of those are nurses and midwives, so about 5,500 staff in total. And we have a 12% vacancy, so we have around about 400 vacancies, and this month, for the first time, we've actually topped 500 nursing and midwifery vacancies across our trust. So we have 90 odd wards, 700 beds, lots of places to sort of soak up those vacancies, but it's a huge challenge for us, and it isn't going to get immediately better, so we do have to look at alternatives. But we certainly do have to think about how we are going to keep our staff happier and also in the jobs that we want them to be in under such difficult circumstances, with large volumes of patients needing services, getting sicker increasingly. And really we know that staff shortages, because we've got lots of research now that tells us that staff shortages mean that we have poorer patient outcomes, and we've got much decreased satisfaction and much more likely to leave our trusts. And what we needed really was to think about flexible and innovative solutions to retain those workforces, but also how we were going to address those workforce challenges locally. And also we had our staff telling us, 53% of that workforce that I was talking about are band 5. These are junior members of staff, often early into the profession. We have huge attrition rates with our nurses and midwives almost immediately as they come out of clinical practice, out of university into clinical practice. But we also have quite a big problem around 4 or 5 years in, so when people really see exactly what they've let themselves in for, and they can't sort of really face the next 25 years in such a busy and difficult environment. People were telling us that they had this desire to remain in clinical practice in some capacity or another, but actually they also wanted other opportunities on top of that. They wanted those career opportunities earlier on. They wanted to see insight and exposure and skill development and all the things that we talk about in relation to volunteers. This is what our staff are telling us they want, and it isn't unusual to see our medical colleagues who have this really well thought out of how they're going to develop people as they come into the profession. So we decided that we were going to begin this fellowship. It's got a ridiculously long title, and I've had some stick on Twitter for that, but this was about trying to convince our chief nurse that she needed to invest in this. So we know we've got all of these vacancies, we've got financial difficulties, as many NHS trusts, and we were asking for investment. So we went straight in there for, we're going to call it the Chief Nurse Fellowship, in the vain hope that she would be more interested if she had a fellowship named after us. It's as base as that really, and it helped us with our cause. So we did establish this programme in 2016, and actually what I should say is what is most essential is that we had to get Trust Board sign up for this, so we were looking for some capital investment. We were looking for us to use money in a different way in nursing. And so we took this quite early on to the Chief Nurse and to Trust Board for it to be agreed at a Trust Board level, and we found that that's been essential in being able to both maintain it throughout even more difficult financial times, but also to kind of continue to do this over the last couple of years. So it's got two components, this programme. So we're looking for very junior nurses who have just come into the profession, and that's junior in years qualified, not junior in years age. So we have had people across a wide spectrum of ages that have come into this, because people come into nursing at different entry points. And what we were looking to do was to really think about development for individuals in a bespoke way, so thinking about what individuals wanted, and we work quite closely with individuals who come onto this programme We coach them one-to-one, we think about their strengths and weaknesses and their talents, and we're looking to develop them. It's very much about clinical transformation, leadership and mentorship, so it's about thinking about how we can instill leadership in very young in qualified, not young in years, as people keep reminding me, we're not looking for 20-year-olds or anybody. But it's really about ensuring that we make this as bespoke as possible. And then component 2 of the programme, we get them to do a quality improvement and practice development activity, which is then going to be undertaken by the Chief Nurse Fellow themselves. So we're looking for people to bring onto a programme for a year. They get 1 day a week with us out of clinical practice, so they maintain most of the time in clinical practice. They spend 1 day a week, and they often are people who are looking to do practice improvement. They have to come to us with an idea. We put these out as kind of job adverts, if you like. People have to apply for them, so they have to come ready-made with a project. But it really is about working one-to-one with them to get the best possible outcome. And what we say to the fellows right at the very beginning is, this is not necessarily about the project, it's about developing the individual, but often the project actually also becomes extremely successful in its own right. So it's very much a partnership approach between corporate nursing, that's where I'm situated, but also with our divisional nursing lead colleagues. So we have 5 divisions at NUH, and what we're looking to do is work with divisional leads to identify individuals and talent spot them quite early on to come onto the programme. We do this via a recruitment process, and as I say, it's 1 day a week out of clinical practice, which can feel quite a lot when you've already established vacancies within your clinical area. And we give academic and clinical mentorship because we want that quality improvement project to be as robust as we possibly can. That's why we give them the quality improvement methodology training to ensure that that's the case. We've had some fantastic fellowships. Jodie is a good example. She was a newly qualified staff nurse who came to work in our emergency department. And one of the things that we found is because we take people really early in their career, they come into an area and they spot where all the gaps are. And I think there's research out there that suggests that within 8 months we're able to socialise our newly qualified nurses into our culture. So they stop seeing things, or they stop at least trying to change things within roughly about 8 months, because they just get sucked into the culture as they get more further into their career. And Jodie came to us because she was really interested in improving the care of mental health patients within the emergency department. What she recognised is that we have all of these care pathways. They're on the wall, laminated within the ED, sort of in the staff room. All of these care bundles for people with physical disabilities. But for those patients with mental health, trauma, acute mental health problems, it was kind of a bit more fluid. People weren't necessarily sure. And as a newly qualified nurse, she didn't feel particularly confident and comfortable treating somebody with acute mental health crisis, because it's not something that she'd been particularly exposed to while she was in her training. So she set about trying to write one of these care bundles. You know, she's having to work with our deliberate self-harm team, experienced mental health practitioners, consultants, and it really starts to get people to think about how they bring together a team of people that are going to make change possible. They learn very quickly that 1 year is not enough to make significant change in the NHS. That's one of the problems that we have. It even feels like it changes a lot, but actually it's really difficult to establish change in the NHS. And at the end of her fellowship year, as with many of the nurses, even though they're very junior and very newly registered, often go on to do other jobs. So within a year often go up to band 6, because these young people have been talent spotted, and they're often really driven and they're interested in change, and we do have problems with deficits, etc. So we've had some amazing projects, some amazing outcomes, and I haven't got the statistics with me because Jodie did this when we came to the awards, but she's managed to significantly reduce the length of time that people spend in the department. She's managed to isolate an area now that's been decorated and has some facilities in it to support people that's a lot quieter that come in with acute mental health crisis. So she's done a significant amount of work and managed to make some great changes, which has been phenomenal. We have another member of staff, Sharon, who came into nursing actually in her early 40s, having done a wealth of different jobs across a number of different sort of spectrums. She'd been in kind of hotel management, she'd worked in a supermarket, and she came to us as a newly registered nurse. And having done a placement in a clinic as a student nurse where they saw patients, recognised that when she came to work on our specialist receiving unit, which brings in patients who are generally post-chemotherapy, who have problems with their kidneys, so we have this direct entry onto the ward, they don't have to come through ED. And she recognised with neutropenic sepsis patients that the pathway, they generally came into hospital, they were experiencing temperatures, they had a set of bloods done, they were often started on antibiotics, could be admitted and waited up to 8 hours for their treatment pathway to be decided by medical staff, waiting long periods of time often for blood results to come back. What she did was she decided that she was going to use the blood gas analyzer that they'd got in the clinic that she'd been working as a student. She was going to take the syringe where the blood had been taken down to the analyzer and get the blood results immediately, so that the medical staff could then make the decision as to whether or not the patients needed antibiotics on the spot. Then they could be admitted if they did, or they could be discharged home. And she reduced the pathway of this particular group of patients by, in some cases, up to 7 hours. And she was very newly registered, so it's a fantastic project. And often it's just about giving people the opportunity to look at that. We also had somebody that was looking at transition from children's to adult services. And one of the things that Frankie learned was how difficult it was to change policy. You know, she looked at the literature a lot. There's so much literature about how difficult it is for people to transition from children to adult services. And yet we still don't have that right. You know, we have 35, 40 years of research in nursing, which is unusual because nursing doesn't generally have a lot of evidence base around many of its things that it does. And she discovered this wealth of literature, and yet still we find it very difficult to get this period of time in our patients' lives correct. What she did was able to inform and change some of the policy that we have around this, but we do still have such a significant problem with that. And quite often those people that come to us on this fellowship who aren't as successful in changing care often become more successful as individuals because they learn from that kind of negative experience. So whether they have a really great project that transcends into really changing patient outcomes, or whether or not they have less, they often learn great things. We have written a paper on this. It is free to access if you want and are interested in a bit more detail. But I think we started off with 6 fellows in 2016, and people often ask me, how is it funded? Well, we do this kind of really pathetic maths as it happens, because it's not real money, but we say we have all of these vacancies, we have all of this money that generally goes on the agency spend, but we're pretending we're using some of it for the fellowships. But this is about transformational leaders within our organisation seeing an opportunity for some of our newly registered nurses and signing up to it no matter how difficult it gets. We say 1 day a week, it's often 2 days every 3 weeks or a month. People do struggle to get off the wards, but we do try and commit to this, and we do try and support it as much as we can. But to date, we had 22 fellows when we wrote this for the presentation in the middle of the year. We now have 29 fellows. We had retained them all in the trust, but someone's just flown to New Zealand, which is really disappointing. We're very cross with her, but she has this fantastic life planned outside of our organisation, so we can't really stop her. But many of them are moving into junior leadership positions, and because this started in 2016, many of these have now gone on to be ward leaders, they've gone on to be project nurses, they've gone on to be specialist nurses, which is fantastic. And here's just a couple of quotes from some of those individuals who have had the opportunity. I'll try and read that so that I don't flip it on too quickly, but I always end up reading it fast because I know what it says. Right, I'm going to change it now, but I'm happy to go back if people want to look at it. What we found is that people get individual exposure, insight and growth, and this isn't rocket science. This is something that our medical colleagues have been doing for such a long time, but it is very unusual to see it in nursing. It's often something that people have found that are giving them that kind of broader context of the NHS that you often don't see if you're in silos in your own clinical area, giving people an understanding and networking. Often people who are in very junior positions don't understand how the finances, how the general management in organisational directorates work, how, because you're working in clinical care delivery, how there are other members of the team who have to be responsible for how that's operationalised. And really, you know, the initiatives and projects that have been disseminated have often been published. People have often gotten an academic publication out of that. That enhances their CV, it gives them greater opportunity as they start to move through their career. Some of them have been shortlisted for national awards. We encourage them to put their work on NHS Fab Stuff so that other people can access that, so that they can see what people are doing. And also thinking about how they can work with other people nationally to think about how their innovations can be moved into clinical practice. When we first started this project, everybody was like, oh no, we can't have a Chief Nurse Fellow, and we talked most of the divisions into having one. And now, if there's a project that needs doing, without fail someone will say, well, can't we have a Chief Nurse Fellow? So it's been really successful in getting people to think about doing things in a different way. There has been a lot of national interest in the programme and how it works. We held an event a few weeks ago where we had 5 other trusts and fellows from within those trusts who attended our organisation. People have done it in a slightly different way. There's been further innovations, fantastic chief nurse in Gloucester who has done a leadership apprenticeship alongside this, so drawing down on the levy to get a leadership qualification, which has been fantastic. Although within a year trying to do a clinical project as well as a leadership qualification has been quite challenging for some of the fellows. We've done stuff like gone and visited the NMC, so taking some of our fellows to see how the NMC works, being involved in some of the, in watching fitness for practice, but also in the consultation around fitness for practice, so really starting to piece together what that looks like. And I think we are trying to grow clinical academics and future leaders, so I work across research and innovation and clinical practice. I work in acute medical admissions myself, as well as having a research portfolio. And actually we wanted to bring people into a clinical academic career. We've lost most of them to leadership, to be honest, because they're spotted quite early on and they go off in leadership positions. But that's fantastic, really, and I know we'll get them back into our sort of clinical academic net at some point, so that's great. So it's been a fantastic project, and there's some of the fellows, the original cohort of the fellows there. We even have a Chief Nurse Fellow baby, because somebody gave birth halfway through their fellowship, so that's been great. But that's it, I think. Yeah.